Good afternoon. I'm Ann Dunkelberg, Associate Director and the Program Director for Health and Wellness at the Center for Public Policy Priorities, and I'm here testifying in support of HB 565. I'm going to focus on the Medicaid portions of the bill. My brilliant coworker Stacy has talked to you about some of the commercial market parts of the bill. But first I want to thank Chairman Coleman for authoring the bill and thank Chair Lucio and this committee for bringing this important issue back into a discussion after a long time without a formal hearing. Section 1 of the bill is an unusual approach to revamping the Medicaid program to better serve youth with disabilities and youth who are in the state's foster care system. And I do not pretend to be an expert on either of those topics, so I will leave commentary on that to some of my colleagues. I'm mostly here to show really strong support for Section 2, which lays out a pretty detailed approach to providing coverage to the great majority of our parents of our children who are on Medicaid, who are not covered today. This is often misunderstood by members of the legislature. We cover about 3.2 million kids on any given day right now in Medicaid, but only about 150,000 of their parents qualify. So this proposal in Section 2 would pick up those parents as well as other adults who don't have dependent children at home, which although we often think just of the low-income parents, we have a fair number of adults who are under 65, but they have a developing chronic illness or the beginning of a disability that has reduced their earning and then maybe their capacity to work full-time, and it has reduced their earnings to where they fall into this group. We, as an organization, CPPP, would prefer, this is a pretty detailed approach that has been laid out by Chairman Coleman, and we would prefer probably a simpler Medicaid expansion like our neighbors in New Mexico and our neighbors in Louisiana have done. But we will be wildly enthusiastic about any progress we can make on covering our low-income adults in Texas. And I think that this bill does a great job, without going into all the detail that's in it, of laying out all of the options that states do have to craft a Medicaid expansion in various different ways. We have a lot of flexibility, and that's evidenced by the states like our neighbor Arkansas and another 8 states that have expanded Medicaid under 1115 waiver authority. I'm going to cut out a few of my talking points because you've got a lot of witnesses who are going to cover some of these things, but a couple of things I did want to point out that might not come up in other people's testimony is that when the Kaiser Family Foundation looked at our population that's left without coverage as a result of not having Medicaid expansion, which, as I said, includes both parents and adults without dependent children. It turns out that 74% of those adults are in a worker-headed family, if either working themselves or the other parent is a working member, and that 74% of our folks who are left without coverage because we haven't done this are people of color. So by leaving this estimated $8 to $10 billion a year in federal funding every year that we are not getting this, we are also disproportionately shortchanging working poor families and families of color. I also wanted to mention that there's a strong body of research from the other states that have done Medicaid expansion. As you know, there are 36 states that have done that so far. And one of the things that they found, Ohio did a great study that showed that their parents and other adults in that program said that having this coverage made it much easier for them to work. Over 80% of them did. And about 60% of the folks who weren't employed at the time they did the survey said that having health coverage made it easier for them to do job search. We've got research that's been done in Arkansas, Michigan, Montana, and Virginia have all reported savings to their state's general funds from doing Medicaid expansion. That's largely savings on mental health spending and criminal justice spending. And finally, I want to mention a point that I think has been touched on and will be touched on by other speakers, which is that another really important reason for renewed attention to this topic is the fact that we are staring down the phase out of our current 1115 waiver, which, as you may recall, is around $6.2 billion all funds per year, and so that means about $4 billion of it is actually net federal funding income to Texas. We're staring down the end of that, And it turns out that doing a coverage expansion, whatever route we take to do that, is one of the most powerful tools we have for holding on to that additional funding that helps our hospitals, as well as one of the strongest tools we have for trying to fold in the innovative projects in mental health and other areas that have been done around the state under the so-called DSRIP, Delivery System Reform Projects. Those are wildly popular and are providing really important services around the state. One of our problems with not having coverage for most of our adults in Texas is that you can't build those innovative practices and policies into your Medicaid program if you don't cover adults. We can build the innovations for children into our program because we have good, robust coverage of kids, as I mentioned, but we don't have any way to build those in to Medicaid for adults. So I'm going to wrap my testimony up with that. I think you're going to hear some other great testimony from other stakeholders, but I'm happy to answer any questions you might have.
Dr. Oliverson?
And I appreciate your testimony. Does this take the place of the L15 waiver? Is that the vision here? This would just replace that?
I don't see them as 100% interchangeable. I don't know.
Because this doesn't have the DSRIP funding in it, right?
The DSRIP funding, as you know, doesn't cover anybody. There's no coverage being provided. But to the extent that a DSRIP project pilots some kind of innovative mental health project and that's primarily used by adults, one of the things that the feds told us when they approved our waiver was, this is not going to last forever. Our expectation is that you take your DSRIP, you identify best practices, and then you build them into your Medicaid program. And again, to the extent that we've identified best practices through DSRIP that are for adults, we can't build them into our Medicaid program because we're not covering those adults.
So under this program, you're anticipating this is not essentially full coverage with this would function more like a commercial product where the patient would have copays, deductibles.
I think it would be, the anticipation is it would be comprehensive coverage. I don't think we've had any 1115 waiver or other straight expansions that weren't a comprehensive benefit package, but under federal law that can be modeled on a commercial product and absolutely can have copayments and within certain limits. And not, I don't think they use deductibles much in other states because obviously you're dealing with a below poverty population, but definitely cost sharing, which can include enrollment fees or freemiums.
Okay, thank you.
Chairman Turner?
Thank you, Mr. Chairman. And can you go back to on the funding aspect for just a second? I want to make sure I caught the numbers correctly. That if we passed this bill and did adopt Medicaid expansion in Texas, did you say it's worth about $8 to $10 billion a year? Did I hear that right?
It did. We haven't had any internal Texas updated analysis for a number of years, but there are a number of different national analyses, and the ones that have come out in the last 2 to 3 years have put that number between $8 to $10 billion a year.
So $16 to $20 billion a biennium for our sort of budget purposes as we think about our two-year budgets additional. So I know one of the arguments in the past against moving forward on Medicaid expansion has been, well, despite whatever federal funding is, there's going to be a cost to the state. Can you talk about a little bit about what the federal share is and what the state match is, but then also about the savings that you've seen other states realize as a net from doing this? So
let's see, one thing at a time. The federal government would pay 90% of the cost for this adult population. So that's quite a bit higher than they do even for, well, not for CHIP now, but that's quite a bit higher than the regular Medicaid match. So that was supposed to be a strong incentive for states to do that. The savings that other states have had, I don't want to get too much in the weeds, but there's a criminal justice aspect because you're actually able to pick up most of your hospitalizations for people in your state prison system through Medicaid if you construct that process correctly, and so that's a big savings for folks. But I think there's also a revolving door savings because obviously we've had a whole lot of attention on substance abuse disorder treatment and mental health conditions, and to the extent that we can get a lot of folks who are struggling with chronic mental illness into medical homes and get them treatment, et cetera, that definitely, and a steady access to medication and all of those things, that definitely helps that revolving door of people with substance use and mental health issues cycling through the jails as well. It's not a panacea, but it is a huge step forward when you don't have to deal with that issue of access to care. And I'm sorry, the other direct state spending on mental health, that tends to be one of the areas where states do a lot of GR spending, even a state like Texas that doesn't have huge GR investments outside of Medicaid. But that is an area where all of the states that have done expansion have seen big advances. That's just within the state budget. There's also, as you know, there are multiplier effects that happen in the economy, and there have been Texas economists who projected that, the tax revenue that would be generated from the additional economic activity that would come with another $8 to $10 billion in healthcare spending would also be beneficial and reduce the state's costs. But that's one step removed from direct impact.
Sure. And if you say stepping away from the state budget, but still talking about public money, for those of us in large urban counties where we have a public hospital district, obviously those hospital districts, whether it's JPS in Tarrant County or Parkland in Dallas, that they're primarily, they bear the brunt of uninsured residents of that county. When people have an accident or a medical emergency or an illness, they go to those public hospitals. By increasing the level of coverage, would we not also reduce the impact on the property taxpayers who fund those hospitals?
This is absolutely, and I don't have, you may have some other folks who will testify. I know I've seen some great estimates from folks like Bexar County and Harris County about what proportion of their programs that they operate for their uninsured residents today that would be picked up by this program and thus would reduce 100% local property tax dollar funding with 90% federal funding. I believe Harris County at one point said it would be like 55% of the people on their Gold Card program, just for one example. So it would definitely relieve some of the costs that are being carried by particularly our urban hospital districts. There's also, as you may know, a very complex layered system of supplemental payments for Medicaid that are, currently supported almost entirely by our hospital districts and a few other entities, and this would reduce some of the reliance on those supplemental payments. Texas is currently the state that has the most reliance on these supplemental Medicaid payments that are actually mostly outside of the state budget.
Outside the state budget, so are they the federal dollars, or? They
draw federal dollars, but they're either using local dollars or local provider participation funds.
As the match.
To draw down the match, yeah. So they are not being appropriated through the state budget for the most part.
Okay. All right. Thank you very much.
Members, any other questions? Thank you so much, ma'am.